I want you to imagine just for a second a chemical factory operating right inside your own body.
A highly volatile one, yeah.
Exactly. And this isn't just, any factory. It produces substances so corrosive, I mean, so incredibly powerful, that if you were to take a piece of raw steak and drop it into a vat of this stuff,
It would just dissolve.
it would completely dissolve. Yet, day in and day out, this factory operates completely safely inside you.
Right, it's heavily fortified.
Perfectly contained. The security protocols are flawless until suddenly a single microscopic switch gets flipped.
And that's when things go wrong.
Yeah, the factory starts turning its own weapons on itself.
It's an incredibly fragile binary. One moment you have this perfectly orchestrated, highly evolved digestive process keeping you alive and nourished. And the next, you have total internal warfare.
It's sudden, it's devastating, and it completely hijacks your biology.
Yeah, it really does.
It's an abrupt, fiery rebellion. And we are talking, of course, about the pancreas.
Specifically, a condition called acute pancreatitis.
Which, to be honest, I always knew was bad, but I didn't fully grasp the scale of it. It is the leading cause of hospitalization for gastrointestinal disease in the entire United States.
Yeah, it's a massive issue.
We are looking at over 275,000 hospital admissions every single year. So our mission for this deep dive today is to completely demystify this fiery rebellion.
Uncover the culprits.
Right. We're going to uncover the really surprising culprits behind it and explore a massive fundamental paradigm shift that has recently, completely rewritten how the medical world treats it.
I think that context is crucial to establish right up front.
Sure.
Because while this condition is incredibly common, predicting its clinical progression is astonishingly complex.
Right.
You have this organ that is absolutely essential for life. But when it becomes inflamed, the clinical course can vary wildly.
How wildly?
Well, sometimes it's a mild, self-limited discomfort. Other times, it rapidly evolves into a severe systemic cascade of multi-organ dysfunction with a frighteningly high mortality rate.
Right.
Yeah, the greatest challenge for a physician isn't just diagnosing the initial spark. It's predicting exactly how far the fire is going to spread.
Okay, let's unpack this from the ground up, because before we can really understand how this factory breaks down, we have to understand where it is and what it normally does.
Absolutely.
I like to think of the pancreas as this highly specialized, dual-purpose facility. It's tucked away deep inside you, behind the stomach, and the medical term for its location is retroperitoneal.
Right. Retroperitoneal.
What does that actually mean for the patient or the doctor?
So retroperitoneal literally means behind the peritoneum, which is the membrane that lines your abdominal cavity.
Okay.
Your stomach, your liver, most of your intestines. They're all inside the peritoneal cavity, floating relatively freely.
Like in a bag.
Yeah, like in a bag. But the pancreas is plastered against the back wall of your abdomen, sitting right in front of your spine.
Oh, wow.
You're looking at a skeletal map. It's sitting right between the L1 and L2 vertebrae.
So it's buried deep.
Exactly. It's essentially hiding. And that location is a huge part of why it's so mysterious and sometimes difficult to examine.
Because you can't just press on it.
Right. If a doctor presses on your stomach, they are feeling the stomach and the intestines acting like a giant soft cushion over the pancreas.
That makes sense.
Structurally, it's physically divided into 4 parts.
Wow.
You've got the head, the neck, the body, and the tail.
And it stretches across.
Right. Yeah, stretching right from the duodenum, which is the first part of your small intestine, all the way over to the hilum of your spleen on the left side of your body.
That location explains why, when something goes wrong with it, people often feel the pain radiating straight through to their back, right?
Spot on.
Because it's physically sitting right against the spine.
Yeah, that radiating back pain is a classic clinical hallmark. You see it all the time.
Okay, so regarding its function, let's look at this dual-purpose factory analogy. The pancreas has 2 distinctly different but equally vital jobs.
Right, endocrine and exocrine.
First, you have the endocrine function, and this is the one most people are probably familiar with, at least in passing. This is handled by specialized clusters of cells called the islets of Langerhans.
Yes, and think of the islets of Langerhans as an internal hormone dispensary.
Okay.
They make up only a tiny fraction of the pancreas's total mass, but they secrete critical hormones directly into your bloodstream.
Like insulin.
Exactly. They produce insulin to lower blood sugar, glucagon to raise it, and somatostatin to regulate the whole system. They meticulously govern your metabolic fuel.
So that's the blood sugar control center. That's job one. But then you have the exocrine function.
which is where our focus is today.
Right. And this is the side of the factory we really need to look at.
The exocrine tissue is the heavy industry side of the factory.
Yeah.
It produces a massive volume of highly potent digestive enzymes.
Like the stuff that dissolves the steak.
Exactly. You've got lipases to break down fats, proteases to break down proteins, and amylases to break down carbohydrates.
Okay, so a whole chemical cocktail.
Yeah, and unlike the endocrine hormones that go into the blood, these exocrine enzymes are delivered via a system of physical like actual pancreatic ducts directly into the duodenum.
Straight into the gut.
Right. They mix with the food you just ate to dismantle it into absorbable nutrients.
Okay, wait, here's where I have to stop you because this is where my mind kind of gets blown.
Sure.
If these enzymes are so incredibly good at digesting food, if they can literally tear apart a piece of meat you've swallowed, why don't they digest the pancreas itself?
That is the big question.
I mean, the pancreas is made of meat, right?
Yeah.
It's made of proteins and fats. How does it hold these chemicals without melting?
That is the fundamental biological riddle.
Yeah.
How do you store a bomb without it going off?
Exactly.
Well, under normal, healthy conditions, the pancreas manufactures these enzymes in an inactive precursor state. We call these inactive forms zymogens.
Zymogens. So they are like weapons with the safety catch left on.
Exactly. The safety pin is firmly in place. They are packaged tightly inside tiny storage units within the cells called zymogen granules.
So they're boxed up safely.
Right. They travel safely out of the cells, into the tiny ducts, and finally down the main pancreatic duct. The safety is only supposed to be switched off once they are far away from the pancreas, having securely reached the gut.
How does the gut know to turn them on?
Inside the duodenum, there is a specific enzyme called enterokinase sitting on the intestinal wall.
Like a trigger.
Yeah, when the inactive zymogens bump into the enterokinase, the safety pin is finally pulled. The weapons go live, but they're safely mixing with your food, not your organs.
That is an incredibly elegant system. So the spark of acute pancreatitis, the entire core of the disease, must be when that safety system fails.
Precisely. The core concept is premature activation.
Okay.
For various reasons we'll get into. That safety pin gets pulled inside the pancreatic tissue itself before the enzymes ever reach the gut.
Oh, no.
Yeah, the proteases wake up and immediately look for proteins to dismantle. And since they are surrounded by the proteins of the pancreatic cells, they begin to digest the very organ that created them.
Autodigestion.
Yes, autodigestion. It triggers an abrupt, explosive, inflammatory response.
Because your body realizes it's under attack.
Right, the immune system senses the tissue being destroyed and rushes blood and white blood cells to the area, causing massive swelling and heat.
Which brings us to how doctors actually classify the battlefield once this destruction starts.
The staging, yes.
When I was looking into this, there's a standardized framework called the Revised Atlanta Classification. It breaks down what the damage actually looks like, the morphologic subtypes. Let's make sure we understand the difference here.
Sure.
The first type is interstitial edematous pancreatitis. This is where you have inflammation of the pancreatic tissue and the fat around it, but there's no actual tissue death.
Correct. Edematous refers to edema, or swelling from fluid buildup.
So it's just really swollen.
The tissue is angry, it's swollen, the blood vessels are leaking plasma into the spaces between the cells, but crucially, the blood supply itself is still intact.
The plumbing is still working? Sort of.
The blood flow is yes. Oxygen is still reaching the cells, so the tissue is surviving. This is the more common, generally less severe form of the disease. Most patients with this form will recover completely as the inflammation subsides.
But the other subtype is the one that really scares the medical team, right? Necrotizing pancreatitis.
Yes, necrosis meaning actual tissue death.
So the tissue is actually dying inside you.
In necrotizing pancreatitis, the autodigestion and the subsequent swelling are so severe that they literally crush the blood vessels feeding the pancreas. Or the enzymes directly destroy the blood vessel.
So it chokes itself off.
Either way, the blood flow stops. Without oxygen, parts of the pancreas or the fatty tissue immediately surrounding it die and begin to rot inside the body.
That sounds horrific.
As you might imagine, having dead necrotic tissue inside your abdomen is a catastrophic scenario. It becomes a prime breeding ground for bacteria, leading to terrible infections and a vastly higher risk of long-term complications or death.
And beyond just what the tissue looks like on a CT scan, they also stage the overall severity of the patient's condition into 3 clinical grades, right?
That's right.
There's mild acute pancreatitis. This means there's no organ failure and no local or systemic complications. The fire is contained to the pancreas.
Exactly. The fire is localized.
The mortality rate here is around 3%, which is still serious but manageable.
Right. The patient is in pain, but their lungs are working, their kidneys are filtering blood, and their heart is pumping normally.
Then there's moderately severe acute pancreatitis. This is where the fire starts to smoke out the rest of the body.
Starts to spread its impact.
You might have some transient organ failure, meaning an organ like your kidneys struggles to keep up, but recovers in under 48 hours, or you develop local complications like acute collections of fluid bubbling up around the pancreas.
And finally, the nightmare scenario. Severe acute pancreatitis.
Which means
Persistent organ failure lasting more than 48 hours. This isn't just a sick pancreas anymore. It's a systemic collapse.
how does it cause systemic collapse?
The massive inflammation in the abdomen releases cytokines, inflammatory alarm signals into the bloodstream. These signals travel throughout the body, causing blood vessels everywhere to leak.
Oh, wow. Everywhere.
Yes. Fluid floods into the microscopic air sacs of the lungs, causing acute respiratory distress syndrome. The kidneys lose their blood flow and shut down.
So your lungs fill with fluid and your kidneys die.
Exactly. The cardiovascular system struggles to maintain blood pressure. It's multi-organ involvement, and the mortality rate can skyrocket up to 20% or even higher if the dead tissue becomes infected.
I think it's so important for you listening to understand this escalation. Because if you or a family member ever face this diagnosis in an emergency room, hearing the doctors throw around terms like interstitial or necrotizing isn't just abstract medical jargon.
No, it's critical information.
Understanding these specific terms is critical for knowing what level of fight you are in for. It's the difference between resting in a standard hospital bed for a few days versus requiring intense, multi-week ICU monitoring with ventilators and dialysis machines to keep the rest of your body from failing.
The stakes are incredibly high from minute one, which is exactly why the initial moments in the emergency room are so critical and so incredibly fraught with danger.
Let's transition right into the ER then. Because severe pancreatitis can be fatal, catching it early is paramount. But as you look at how this presents clinically, you realize this disease is an absolute master of disguise.
It really is a chameleon.
I kept thinking about the sheer terror of being an ER triage doctor when a patient comes in screaming with agonizing abdominal pain, because acute pancreatitis mimics almost everything else that can go wrong in your torso.
That's the real challenge of emergency medicine. The greatest danger in the ER is cognitive bias, specifically premature closure.
Meaning they stop looking for answers too early.
Exactly. If a physician sees a patient clutching their upper abdomen, vomiting and sweating, and immediately assumes, oh, this is a bad stomach bug or maybe food poisoning, they narrow their focus.
And miss the real problem.
And when you narrow your focus too early, you might completely miss a critical mimic. Acute pancreatitis is what we call a diagnosis of exclusion in many ways, because it has a massive lineup of lookalikes that can kill the patient just as quickly or quicker if missed.
I want us to really dig into this lineup of lookalikes because the sheer variety is astounding. It's not just a list, it's a minefield.
It's a huge list.
Let's start with the gastrointestinal mimics. The most obvious one is peptic ulcer disease, but not just a regular ulcer, a perforated ulcer. How does that mimic the autodigestion of the pancreas?
Well, a peptic ulcer is a sore in the lining of your stomach, or duodenum. If that ulcer eats all the way through the stomach wall, a perforation, it creates a hole.
Meaning stomach acid leaks out.
Suddenly, highly acidic stomach juices and bacteria leak out into the sterile peritoneal cavity. This causes peritonitis, a massive instant infection and inflammation of the abdominal lining.
So it hurts exactly the same way.
The patient presents with agonizing, sudden onset epigastric pain right in the upper middle abdomen. The belly becomes rigid, like a wooden board. It looks and feels almost exactly like a severe pancreatitis attack.
And then you have problems with the gallbladder. Acute cholecystitis, which is inflammation of the gallbladder itself, usually from a stone stuck in its exit duct.
Right, very common.
That shares overlapping features like right upper quadrant pain that radiates and fever. But closely related to that, and far more dangerous, are choledocholithiasis and cholangitis.
Yes. Choledocholithiasis is a mouthful, but it just means a gallstone has migrated out of the gallbladder and gotten stuck deep in the common bile duct.
Okay, so it moved and got stuck.
Exactly. If bacteria build up behind that stuck stone, you get cholangitis, a severe, life-threatening infection of the entire biliary tree.
How do they tell the difference?
The clues a doctor looks for here to distinguish it from pure pancreatitis are jaundice, a yellowing of the skin and eyes because bilirubin is backing up into the blood, along with spiking fevers and a rapid systemic inflammatory response.
Okay, and what about the more common everyday stuff, like gastroenteritis, your standard stomach bug? It gives you nausea, vomiting, intense abdominal cramps. Why wouldn't a doctor just assume it's that?
They often do. Initially, it's a very common trap.
Yeah.
But the key differentiator is the lab work.
The blood tests.
Right. Gastroenteritis is an infection of the gut lining. It doesn't cause the massive elevation in pancreatic enzymes in the blood that we see when the pancreas is actively destroying itself.
You also have to rule out a mechanical bowel obstruction where the intestines are physically twisted or blocked by scar tissue.
Right. And for that, doctors rely on imaging. They'll look for distinct air fluid levels on an X-ray or CT scan.
What does that look like?
Imagine a kinked garden hose, the water and air back up behind the kink, creating visible layers on an X-ray. Or, similarly, they look for a perforated viscus, which is a tear in any of your hollow organs like the colon.
So they look for a leak?
For that, the radiologist looks for free air floating around in the abdominal cavity on imaging, because air belongs inside the intestines, not outside them.
Those are all major GI emergencies, but this is where the diagnostic puzzle gets truly treacherous. Acute pancreatitis doesn't just mimic stomach and intestine problems.
No, it goes way beyond the gut.
It perfectly mimics critical vascular and thoracic emergencies problems with the blood vessels and the heart. And this is terrifying. Let's talk about mesenteric ischemia.
Mesenteric ischemia is essentially a heart attack of the gut.
A heart attack of the gut? That sounds awful.
It is. The intestines require a massive blood supply, primarily delivered by the superior mesenteric artery. If a blood clot breaks off from the heart and lodges in that artery, the blood flow to the intestines instantly stops. The tissue begins to die.
But the pain presentation for this is really weird, right?
It is, and it's a classic medical trap. The hallmark clinical clue is pain disproportionate to physical findings.
Meaning they look fine, but they're screaming.
The patient is screaming in absolute agony, writhing on the bed. But when the doctor gently presses on their belly, it feels relatively soft, and the patient doesn't necessarily scream louder when pushed.
That is bizarre.
The pain is deep and ischemic. It perfectly mimics the severe, deep pain of pancreatitis. Catching it requires immediate CT angiography, a speckle scan to map the blood vessels before the intestines die completely.
And speaking of heart attacks, an actual myocardial infarction can disguise itself as a pancreas problem.
Yes.
Specifically, an inferior wall MI.
Yes. The bottom wall of your heart, the inferior wall, sits right on top of the diaphragm.
Okay.
And directly beneath the diaphragm is your stomach and pancreas. So if a patient is having a heart attack localized to that bottom wall, the pain doesn't always feel like the classic elephant sitting on the chest or left arm numbness.
It refers downward.
It refers downward. It can present as massive epigastric pain, profuse sweating, and vomiting identical to the pancreas acting up.
So they think it's their stomach.
Exactly. If an ER doctor forgets to run an ECG and check troponin blood tests, they could be treating the stomach while the patient's heart gives out.
Hang on, I just have to pause there. You go to the ER with stomach pain and it turns out your heart is dying. That is why they wire you up to an ECG basically the second you walk through the door.
Exactly. You never skip the ECG for upper abdominal pain. It's an absolute must.
And we cannot forget the aorta. The aorta is the largest artery in the body, coming straight out of the heart and running right down through the back of the abdomen. If something goes wrong there, it's catastrophic.
Truly catastrophic. An aortic dissection is when the inner layer of the aorta tears and blood surges into the wall of the artery, splitting the layers apart.
And how does that feel?
It presents with a sudden tearing chest or back pain. A sharp doctor will look for pulse deficits, meaning the pulse in one arm is vastly different from the other because the tear is disrupting blood flow asymmetrically.
Or a ruptured abdominal aortic aneurysm, a AAA. This is when a weakened ballooning section of the aorta in the abdomen finally bursts.
The patient will present with severe back or flank pain, mirroring the retroperitoneal pain of the pancreas, but they will be hypotensive. Their blood pressure crashes as they internally bleed out.
So if they misdiagnose that...
If a doctor misses a ruptured AAA because they are hyper-focused on the pancreas, The mortality rate is nearly 100%.
It's just a minefield.
Yeah.
And even outside the gut and the heart, the lungs can play tricks on you. Lower lobe pneumonia and infection at the very base of your lungs can inflame the diaphragm.
Right, which sits right above the pancreas.
That inflammation refers pain down into the abdomen, complete with a fever and high white blood cell count that perfectly mimics pancreatitis.
And we haven't even touched the metabolic mimics yet.
Let's talk about DKA, diabetic ketoacidosis, because this one actually broke my brain a little bit when I was reading about it. DKA is a life-threatening complication of diabetes where blood sugar spikes and the blood becomes highly acidic.
Very common in the ER.
What I don't understand is how a blood sugar issue mimics an exploding pancreas.
It's a fascinating double disguise. DKA causes profound systemic dehydration and electrolyte chaos, which manifests as severe abdominal cramping and vomiting.
Okay, so it hurts and you throw up.
But here's the trick. The massive metabolic stress and the altered clearance of enzymes by the struggling kidneys can actually cause amylase levels in the blood to rise.
Wait, amylase? That's a pancreas enzyme.
Amylase is one of the primary enzymes doctors measure to diagnose pancreatitis. So you have a patient with severe abdominal pain, vomiting, and elevated amylase.
It's a perfect fake out.
It looks exactly like pancreatitis, but the pancreas is actually fine. It's the insulin deficiency causing the chaos.
Wait, that is incredibly unfair to the doctor. The test you use to confirm the disease is being artificially inflated by a different disease entirely.
Which is why we don't rely on amylase alone anymore. We rely heavily on lipase, another enzyme, which is much more specific to the pancreas.
Yeah.
But it illustrates the danger.
Just to round out the list of horrors, you also have renal colic, which is the medical term for the sheer, rolling agony of kidney stones passing down the ureter. They need a non-contrast CT scan to catch those.
Yes, the pain from that is incredible.
And finally, viral hepatitis, an acute infection of the liver, which a doctor would suspect if the patient has recent travel history, yellow jaundice, or highly elevated liver enzymes called transaminases.
So when you look at that vast, terrifying differential diagnosis list, the key takeaway is clear. You cannot diagnose acute pancreatitis on a hunch.
You can't just guess.
You cannot eyeball it. Confirming the diagnosis and safely ruling out all those lethal mimics requires a holistic, comprehensive suite of tools every single time.
You need the full workup.
The physician must utilize specific laboratory blood tests like lipase, an ECG for the heart, an abdominal ultrasound to look at the gallbladder, CT scans to check the intestines and aorta, and chest x-rays for the lungs. It is a full system investigation.
Okay, so let's say the ER team has done all that. They've run the gauntlet, they've ruled out the heart attack, they've ruled out the ruptured aorta, the bowel isn't blocked, the lungs are clear.
They've done their diligence.
The labs and the CT scan come back and confirm, yes, this chemical factory is actively self-destructing. The diagnosis is officially acute pancreatitis.
Right.
The immediate next question, naturally, is why did this happen? What flipped the switch on the Zymogen safety pins?
The etiology.
And that brings us to the primary suspects. When doctors are trying to solve the mystery of the spark, they look first at the two main culprits responsible for the vast majority of cases in the United States.
Right. If you are playing the odds, you are looking at two very specific triggers before you look at anything else.
Yeah. Suspect number one is biliary pancreatitis, gallstones. This accounts for roughly 35 to 40% of all acute pancreatitis cases in the U.S.
It's the most common cause.
And this directly goes back to the anatomy we discussed earlier. I think of this mechanism as a catastrophic plumbing disaster. It's mud in the pipes.
That's a perfect analogy. The anatomy of the ducts is the structural vulnerability of the entire system. You have the common bile duct, which carries thick green bile down from the liver and gallbladder.
Right.
And you have the main pancreatic duct, which carries those dangerous, inactive digestive enzymes from the pancreas. In most human beings, these two pipes join together just millimeters before they empty into the duodenum.
They merge.
They exit through a single, shared, narrow opening called the ampulla of Vater.
It's like a Y intersection merging into a single lane right before the highway.
Exactly. And the crazy thing is the size of the stones that cause the problem. When people think of gallstones, they often picture these giant golf ball-sized rocks.
Yeah, the ones that require the whole gallbladder to come out because it's bursting.
Right. But a massive stone is actually relatively safe for the pancreas because a giant stone stays trapped up in the gallbladder. It's too big to enter the plumbing.
So the big ones aren't the issue.
The truly dangerous stones for the pancreas are the tiny ones. Stones that are less than 5 millimeters across, or even just what we call biliary sludge, which is essentially Microscopic cholesterol crystals and thick, tarry bile.
Because they are small enough to enter the pipes, but just big enough to cause a traffic jam.
Exactly. These microliths are highly mobile. They slip out of the gallbladder, travel smoothly down the wide common bile duct, but then they hit that narrow, shared exit lane, the ampulla of Vater, and they wedge themselves right in the opening.
Like a cork.
They act like a cork in a bottle. When that exit is blocked, the liver is still pumping bile, the pancreas is still pumping enzymes, and the pressure builds instantly.
And water, or in this case bodily fluid, always takes the path of least resistance.
Yes. The bile has nowhere to go but backward. Because the pressure in the bile duct is often higher than the pressure in the pancreatic duct, the bile refluxes alongside the pancreatic secretions, pushing back up into the delicate, highly sensitive pancreatic duct.
So it's washing the wrong way.
This abnormal, intense pressure, combined with the chemical irritation of the bile salts washing over the pancreatic cells, stresses the acinar cells to the breaking point. This stress triggers the premature activation we talked about.
The pins get pulled.
The enterokinase isn't there, but the massive pressure and chemical shock cause the zymogens to wake up inside the duct. The safety pins pop off, and the autodigestion begins.
It's just a mechanical plumbing disaster. So how does an ER doctor know if it's a tiny stone doing this? Because 5 millimeters is incredibly small. Does it even show up on a scan?
Sometimes it doesn't show up on a standard ultrasound, but the blood work leaves a very specific footprint. If a blood test shows elevated ALT levels, that's an enzyme called alanine aminotransferase, which lives in the liver, specifically jumping above 150 units per liter, that is a massive red flag.
What does that tell them?
It tells the doctor the liver is backing up, which means the bile duct is blocked, which means this is a biliary cause. And obviously, if the ultrasound or CT scan shows biliary dilation, meaning the ducts are visibly widened and swollen behind a blockage, that confirms it.
And demographically, who is most at risk for this? The literature notes this is more common in older adults, females, and people with obesity. But there was one demographic detail that surprised me, people who are experiencing very rapid weight loss.
Ah, yes.
Why does losing weight quickly cause your pancreas to explode?
It's a metabolic quirk.
Yeah.
When you lose weight very rapidly, say, through extreme fasting or bariatric surgery, your body mobilizes huge amounts of cholesterol from your fat stores to burn for energy.
Okay.
The liver has to process all this cholesterol, and it excretes the excess into the bile. This turns the bile inside the gallbladder into a supersaturated cholesterol soup.
And that forms stones.
The cholesterol crystallizes rapidly, forming dozens of those dangerous tiny stones we just talked about. As the gallbladder squeezes to digest whatever small amount of fat you are eating, it shoots those tiny stones down the duct, triggering the blockage.
That is fascinating. Okay, so that's suspect number 1. But suspect number 2 is alcohol-induced pancreatitis, which is responsible for about 17 to 25% of cases in the U.S.
Right, the second biggest culprit.
Now, the parameters for this are pretty specific. It usually requires chronic heavy alcohol use defined broadly as 4 to 5 drinks daily for over 5 years. It's a long-term buildup of toxic stress.
It's chronic exposure.
Binge drinking alone on a single weekend rarely causes it, unless the person already has some pre-existing head injury to their pancreas.
Yeah.
But here's what I really want to know, and where I need you to break down the chemistry for me.
Sure.
How does a liquid you drink alcohol, which gets absorbed into your blood and processed by your liver, cause a solid organ like the pancreas to suddenly start attacking itself?
It's a brilliant question, and the answer is that alcohol acts like a systematic poison to the factory, attacking it through multiple intersecting chemical and physical pathways simultaneously. Let's look at the chemistry first.
Okay.
There's an oxidative pathway. When your body metabolizes alcohol, it creates a highly toxic byproduct called acetaldehyde. As this acetaldehyde accumulates in the pancreas, it aggressively disrupts a vital cellular balance called the NAD redox equilibrium.
Okay, I'm going to need an analogy here. What is the NAD redox equilibrium, and why does the pancreas care?
Think of NAD molecules as the battery carriers in the factory. They are constantly shuttling electrons back and forth across the cell to keep the machinery running, to generate energy, and to clear out waste.
So they're moving power around.
It's a delicate, fast-paced equilibrium. Acetaldehyde effectively strips the carriers of their ability to hold a charge. The cell is suddenly depleted of energy.
The power goes out.
The internal environment becomes highly acidic and full of reactive oxygen species, free radicals that tear through the cell walls. The cell essentially suffocates and begins to break down.
So the alcohol byproduct is destroying the power grid of the cell.
Exactly. And that's just the oxidative pathway. Then there is the non-oxidative pathway. The pancreas attempts to metabolize some of the alcohol itself, and in doing so, it binds the alcohol to fatty acids, creating compounds called fatty acid ethyl esters.
Are those bad?
They are terrible. Think of them as toxic smog building up inside the factory walls. These fatty acid ethyl esters directly damage the membranes of the acinar cells, the very cells that manufacture and package the digestive enzymes.
So they hurt the storage units?
They weaken the zymogen granules, causing them to become leaky. The enzymes start bleeding out into the cellular cytoplasm where they shouldn't be, increasing the chance of premature activation.
So the alcohol is chemically poisoning the assembly line workers and making the bomb casings brittle.
Yes. But alcohol doesn't just attack the cells chemically. It physically changes the fluid dynamics of the organ. Chronic alcohol use fundamentally alters the physiology of the pancreatic juices. It decreases the amount of water and bicarbonate secreted into the ducts.
So it makes the fluid thicker.
Much thicker. It becomes highly viscous and sluggish. And because the fluid is so thick, the proteins suspended within that fluid begin to precipitate out. They clump together.
Like chunks.
These clumps form literal protein plugs that physically block the tiny microscopic ducts inside the pancreas.
Oh, wow. So just like the gallstone block the main giant exit pipe?
Exactly. But instead of one big cork at the end, these tiny protein plugs act like thousands of microcorks, blocking thousands of microexits throughout the entire organ.
That's horrifying.
The pressure backs up in 1,000 different places, causing micro-ruptures, leaking enzymes, and widespread autodigestion. It is a multi-pronged attack on the organ's structural and chemical integrity.
It's just a brutal, slow-motion demolition. But here is the thing that completely threw me when reviewing the epidemiology. It's a massive paradox.
You're talking about the incidence rate.
Yes. Because despite everything you just described, the battery carriers dying, the toxic smog, the 1,000 microcorks, fewer than 5% of chronic heavy drinkers actually develop acute pancreatitis.
A remarkably low number.
Less than 5%. That means 95% of heavy drinkers whose pancreases are dealing with the exact same acetaldehyde and protein plugs never trigger the explosive rebellion. Why? How does that make any sense?
It is the great paradox of the disease, and frankly, we don't fully have the answer. It heavily implies that alcohol, as destructive as it is merely a sensitizing agent.
So that's not the actual match.
It primes the bomb, but it isn't enough to pull the pin on its own. There must be underlying genetic susceptibilities, perhaps a slight mutation in how a patient clears toxins or specific environmental cofactors like smoking or a high-fat diet that push that specific 5% over the edge into the inflammatory cascade.
It's like playing Russian roulette with your genetics.
It truly is. However, for that unlucky small percentage who do develop it, the consequences are dire. If they survive the acute attack, they are at incredibly high risk for recurrent episodes if they don't achieve absolute sobriety.
Because the damage is done.
And over time, this repeated inflammatory scarring destroys the organ entirely, leading to a condition called chronic pancreatitis.
What does that mean for the patient long term?
It means the factory simply burns down permanently and is replaced by hard scar tissue. That leaves the patient with exocrine insufficiency, meaning they can no longer digest food at all without taking handfuls of artificial enzyme pills with every meal.
They have to take pills just to eat.
And it causes endocrine insufficiency, resulting in severe brittle diabetes mellitus because the insulin-producing cells have been wiped out. Not to mention, the constant cycle of inflammation and cellular repair creates a significantly increased risk of developing pancreatic cancer down the line.
Wow. Okay, so gallstones and alcohol. Those two suspects account for roughly 60% of all acute pancreatitis cases in the U.S.
Roughly, yes.
But if 60% are accounted for, what happens to the rest of the patients? What about the remaining 40%, the people who don't drink and don't have gallstones?
That's where things get very interesting.
Here is where we have to dive into the hidden etiologies, the rare, the weird, and the inherited causes. And honestly, this was the most fascinating part of the biology to me because it shows how many bizarre things can trigger this single switch.
It really highlights how interconnected the pancreas is with every other system in the body and how incredibly sensitive it is to metabolic disruption.
Let's start with the metabolic triggers, because I got really focused on the extremes here. For example, triglycerides. We usually hear about high triglycerides in the context of heart health, eating too much fast food, plaque in the arteries.
All right, standard cholesterol worries.
But if your triglyceride levels soar past 1,000 milligrams per deciliter, which, to give some context, a normal level is under 150. If it hits 1,000, your blood plasma literally starts to look milky and thick.
It physically changes appearance.
That alone can trigger acute pancreatitis. How does fat in the blood melt the pancreas?
It's a condition called hypertriglyceridemia-induced pancreatitis. When the massive amount of lipids fats in the blood flows through the tiny capillary beds inside the pancreas, a local enzyme called pancreatic lipase begins to break down those triglycerides right there inside the blood vessels.
It's digesting the fat in the blood instead of the gut.
Exactly. And the breakdown of triglycerides releases massive quantities of toxic free fatty acids. These free fatty acids are highly acidic and directly toxic to the delicate endothelial cells lining the blood vessels and the acinar cells themselves.
So it's an acid attack from inside the veins?
It causes immediate ischemia, loss of blood flow, and a massive inflammatory response. The clinical guidelines actually stress that if a patient comes in with pancreatitis and they don't have gallstones and don't drink alcohol, checking their serum triglyceride level is an absolute mandatory next step.
Then you have hypercalcemia, which is dangerously high calcium levels in the blood, often caused by an overactive parathyroid gland. High calcium can literally hyperstimulate the cellular mechanisms that secrete the enzymes, causing the cells to basically burn out and rupture.
That's right.
But okay, the trigger that really stopped me in my tracks, and honestly is just terrifying, is the toxic triggers. Exposure to organophosphates, which are potent industrial pesticides, or literal scorpion venom.
Yes, it sounds like science fiction, but it's a very real medical phenomenon.
Yeah.
Certain species of scorpions, particularly the Tedious trinitatis found in Trinidad and parts of South America, possess venom that is a profound secretagogue.
What does it mean?
It means the venom chemically hyperstimulates the cholinergic nervous system, the nerve pathways that tell the pancreas to secrete enzymes.
So it forces it to fire.
When a person is stung, the venom forces the pancreas to violently and instantaneously dump all of his stored zymogen granules at once. It completely overwhelms the ductal system. The pressure spikes instantly, and you get immediate, massive autodigestion.
That is insane.
It's rare globally, but an incredibly well-documented phenomenon in specific geographic regions.
That is just incredible. The venom turns the factory into a bomb. But it's not just exotic venoms and industrial chemicals. Everyday medications can do it too, right?
Absolutely. Drug-induced pancreatitis is a vital consideration for any physician. The list of common offenders is broad, and the mechanisms vary from direct toxicity to allergic reactions.
Like what kind of drugs?
It includes immunosuppressants like azathioprine and 6-mercaptopurine, which are frequently used to manage conditions like Crohn's disease or rheumatoid arthritis. Anti-seizure and mood-stabilizing medications, specifically valproic acid, are known to generate toxic metabolites that stress the pancreas.
What else?
Antiviral drugs like didanosine, anti-inflammatory drugs targeted at the gut like mesalamine. Even incredibly common blood pressure medications, specifically ACE inhibitors, can cause localized swelling in the pancreatic ducts in rare cases.
So if a patient is on one of these common drugs and develops unexplained abdominal pain, the doctor has to suspect the drug, stop it immediately, and see if the fire goes out.
Exactly. It requires meticulous pharmacological detective work.
Okay, so we've got metabolic chaos, venoms, and pills. What about post-procedural and structural causes? Because sometimes the medical treatment itself can be the spark.
That's an unfortunate truth.
I'm looking at ERCP procedures. ERCP stands for endoscopic retrograde cholangiopancreatography, which is ironically a procedure used to look at and fix the bile and pancreatic ducts.
It is an unfortunate paradox of modern medicine. Let's say a patient has a stuck gallstone. To pull it out via ERCP, the gastroenterologist has to navigate a long, flexible scope down the throat, through the stomach, and into the duodenum.
It's a long way to go.
They have to find that tiny millimeter-wide ampulla evader, thread a wire into it, and inject contrast dye under pressure so they can see the ducts on an X-ray.
That sounds incredibly invasive for such a tiny, delicate valve.
It is. That mechanical trauma of the wire, the heat from cutting instruments, the sudden pressure of the dye injection, and the allergic reactions some people have to the dye itself, all of that can be the very spark that severely irritates the pancreas and causes post-ERCP pancreatitis.
The cure causes the disease.
Similarly, general abdominal surgery anywhere near the organ, like stomach or spleen surgery, can cause physical trauma or temporarily reduce blood flow, leading to ischemic inflammation.
And then there are structural issues people are just born with. The plumbing is just built wrong from day one. Things like ampullary stenosis, where the exit valve is just scarred and too tight, or congenital anomalies with wild names like an annular pancreas, where the pancreas physically wraps around the intestine like a tight ring, causing blockages, or colodocal cysts. But this one really caught my eye, pancreas divisum.
Pancreas divisum is fascinating because it's actually a relatively common congenital variant. Up to 10% of the population might have some form of it.
10%. So how does it work?
During fetal development in the womb, the pancreas actually starts as two separate buds of tissue. As the fetus grows, these two buds are supposed to rotate and fuse together to form one solid organ with one large main drainage duct.
Okay, they come together.
In pancreas divisum, that fusion is incomplete. The duct systems never connect properly. So the vast majority of the pancreatic juice produced by the larger portion of the organ is forced to drain out of a much smaller secondary exit called the minor papilla.
It's like trying to drain a fire hose through a garden hose nozzle.
Exactly. For many people, it never causes a problem. But for some, that tiny exit just isn't big enough to handle the volume after a large meal. The fluid backs up, the pressure rises, and you get recurrent attacks of acute pancreatitis.
But there is a crucial dark warning that we have to discuss regarding structural blockages. If a patient is over 40 years old and they come in with their first ever attack of acute pancreatitis, and they don't have gallstones, they don't drink heavy alcohol, their triglycerides are normal, and there's no obvious congenital anomaly like divisum, doctors must aggressively rule out a pancreatic neoplasm.
A tumor?
A tumor. That is a critical life-saving red flag. A tumor, specifically pancreatic adenocarcinoma, growing slowly inside the tissue, might be completely silent and painless for months.
I'd never know it was there.
But as it physically grows larger, it can compress and eventually block the main pancreatic duct. The resulting backup causes an acute attack of pancreatitis. Pancreatitis is just the alarm bell for the underlying cancer.
Wow.
So for a middle-aged or older adult with a first-time unexplained attack, an occult hidden pancreatic cancer must be explicitly hunted for and ruled out with advanced high-resolution CT or MRI imaging. It's a terrifying thought, but catching it because of the inflammation might be the only chance they have. Now, if tumors and anatomical quirks weren't enough, we also have to talk about the microbial invaders, the infections. I honestly had no idea the pancreas was vulnerable to so many different bugs. It seems so isolated, but it's a target. Let's start with the viruses. You've got the Coxsackie virus, which usually just causes hand, foot, and mouth disease in toddlers. Cytomegalovirus, or CMV, Epstein-Barr virus, which causes mono. All the major hepatitis strains, A, B, and C HIV, can trigger it. Even common childhood illnesses like mumps, rubella, and varicella chickenpox. How does a virus that gives a kid chickenpox or mumps suddenly melt their pancreas?
It comes down to something called viral tropism. Tropism is the ability of a specific virus to recognize, bind to, and infect a specific type of cell.
Like a lock and key.
The acinar cells in the pancreas have surface receptors that these particular viruses can latch onto. Once the virus binds, it injects its genetic material inside the factory, hijacking the cellular machinery to make millions of copies of itself.
And then it bursts.
The cell eventually swells and bursts, releasing the virus, but also releasing all those dangerous digestive enzymes into the surrounding tissue, triggering the wider inflammatory fire. Mumps, in particular, has a very strong tropism for glandular tissue, which is why it swells the salivary glands in the neck, but can also acutely swell the pancreas.
And it's not just viruses. The bacteria get in on it, too. Campylobacter jejuni, which is a really common food poisoning bug you get from undercooked chicken. Legionella, which causes Legionnaire's disease from contaminated AC units. Leptospira, from water contaminated with animal urine. Mycobacterium tuberculosis, literally TB of the pancreas. And Mycoplasma pneumonia, a cause of walking pneumonia.
Bacterial infections usually reach the pancreas via the bloodstream from another primary infection site,
Right.
where they crawl directly up the biliary tree from the intestines.
And speaking of crawling up the tree, we also have to mention parasitic infections. This is particularly relevant in endemic regions around the world or in people who travel heavily. And this is pure nightmare fuel. Parasites like Ascaris lumbricoides. This is a giant roundworm. How does a worm cause pancreatitis?
It causes a mechanical blockage, much like a gallstone, but it's alive. Ascaris worms live in the small intestine, but they are highly motile. They move around.
Oh, gross.
Occasionally, a worm will explore the intestinal wall, find that tiny opening of the ampulla of Vater, and literally crawl up inside the common bile duct or the pancreatic duct. Its physical body blocks the duct, causing the pressure backup and autodigestion.
That's horrifying.
There's also Clinorchus sinensis. the Chinese liver fluke, which infests the bile ducts after someone eats raw, infected freshwater fish. And there are microscopic parasites like Cryptosporidium and Microsporidia, particularly in immunocompromised patients like those with advanced HIV. The differential diagnosis for an infectious etiology is incredibly broad and requires a physician to take a highly detailed patient history regarding travel, immune status, and specific exposures.
Okay, so we've covered the mechanical plumbing, the toxic venoms and pills, the structural quirks, and the microbial invaders. But what if the call is coming from inside the house? What about the immune system and our own genetics?
Autoimmune pancreatitis is a very distinct, fascinating entity where your immune system mistakenly identifies your own pancreas as a foreign threat. There are two main types. Type I is part of a broader systemic condition called IgG4-related disease.
I need an ELI5 on IgG4. What is that?
Sure, the immune system uses antibodies as targeting lasers to mark invaders for destruction. In IgG4-related disease, the body produces an overwhelming amount of a specific subtype of these antibodies, immunoglobulin G4.
So it's making too many lasers.
These antibodies mistakenly taint the pancreas and often other organs like the bile ducts, salivary glands, or kidneys as enemy targets. The immune system swarms the tissue with white blood cells, causing massive fibrotic swelling that chokes off the ducts.
And type 2?
Type 2 autoimmune pancreatitis is similar but specific only to the pancreas, involving distinct lesions called granulocytic epithelial lesions, where immune cells attack the duct walls directly. Both types cause swelling and blockages that lead to acute attacks, but crucially, they respond beautifully to steroid medications that suppress the immune system.
And then there's the pure genetics of it. The blueprint itself is flawed. I saw specific gene mutations linked to this. There's the PRS1 mutation, which directly causes hereditary pancreatitis. There's the CFTR gene, which is the exact same mutation that causes cystic fibrosis. How does a lung disease gene affect the pancreas?
The CFTR gene controls the flow of salt and water in and out of cells throughout the body. In cystic fibrosis, this pump is broken. The mucus in the lungs becomes incredibly thick and sticky, causing respiratory failure.
Oh, and it does the same thing to the pancreas fluid.
Exactly. The pancreatic juices become thick as glue, plugging the ducts and causing autodigestion.
Then there's alpha-1 antitrypsin deficiency.
Yes. Alpha-1 antitrypsin is a protein produced by the liver that normally acts like a chemical fire extinguisher circulating in your bloodstream. Its job is to neutralize rogue proteases, like those pancreatic enzymes, if they accidentally leak into the blood.
So it stops small fires.
If you have a genetic deficiency in this protein, you don't have the fire extinguishers. So when a tiny bit of enzyme leaks out, there's nothing to stop it from starting a massive blaze.
And lastly, there's the SBINK1 mutation. The literature notes this one is specifically linked to something called tropical pancreatitis. What is that?
Tropical pancreatitis is a tragic, chronic form of the disease seen predominantly in children and young adults in South and Southeast Asia. It is a classic, devastating example of genetics intersecting with environment. Patients may have that SBINK1 genetic susceptibility, which makes their pancreas slightly more prone to premature activation. But that genetic flaw is deeply exacerbated by severe malnutrition, oxidative stress, and the dietary consumption of certain cyanogens.
Cyanogens, like cyanide.
Natural toxins found in staple root vegetables like cassava, if they aren't processed and cooked correctly. The combination of the genetic flaw and the environmental toxic stress utterly destroys the organ at a very young age, leading to severe diabetes and massive calcified stones inside the pancreas.
So given all of that, the venom, the worms, the genes, the alcohol, the stones, what happens when doctors run every test, look under every rock, run the CT scans, check the triglycerides, and they still find absolutely nothing? Because the numbers say that in 10 to 20% of patients, despite a massive diagnostic workup, no clear cause is ever found. They label it idiopathic, the mysterious 10 to 20%. Does the pancreas just occasionally explode for no reason?
No, it never explodes for no reason. This is where medical humility comes in. In medicine, idiopathic is often just a placeholder word for we don't have sensitive enough tools to see the cause yet.
So there's always a reason.
Because often, if you refer these idiopathic patients to a highly specialized gastroenterologist for advanced imaging, the mystery begins to unravel. If they do an endoscopic ultrasound, an EUS, where they put an ultrasound probe down into the stomach to look at the pancreas from mere millimeters away, they often find hidden microscopic microlithiasis.
Tiny stones.
That's biliary sludge that was simply too small for a standard abdominal ultrasound to see. Or they do an MRI of the bile ducts and discover a subtle, hidden pancreas divisum that the CT scan missed.
Or they sequence the DNA.
Exactly. The current medical guidelines now explicitly advise that if a patient is under 30 years old, has recurrent unexplained attacks of pancreatitis, and a family history of pancreatic issues, doctors shouldn't just shrug their shoulders and call it idiopathic. They must order genetic testing to look for those PRSS1, CFTR, or SBINK1 mutations. The cause is there. We just have to look harder.
Okay. Take a breath. We've defined the factory. We've diagnosed the rebellion in the chaotic environment of the ER. We've tracked down the suspects, from the mundane 5 mm gallstone all the way down to microscopic genetic typos. Now we reach the climax of the clinical story. How do we actually stop the pancreas from destroying itself and killing the patient? We are moving into the treatment phase. And here is where the narrative gets really interesting to me. Because in recent years, the medical playbook for treating this disease has been completely entirely rewritten. It is a massive paradigm shift in how we handle fluids and food.
Paradigm shift is the exact right phrase. If you look back just a decade or so, the medical dogma for acute pancreatitis was incredibly rigid, universally applied, and, as we recently discovered through rigorous trials, portions of it were actively harming patients.
Let's talk about the great fluid debate. The old school medical mentality. When I first learned about how pancreatitis worked, the old treatment made intuitive sense to me. The pancreas is inflamed, the blood vessels are leaking plasma into the abdominal cavity, the patient is sweating, vomiting, and getting massively dehydrated internally. So the old mentality was flush out the system, aggressive hydration, hook them up to an IV and blast them with liters and liters of normal saline to keep the blood pressure up.
And the physiological rationale seemed totally sound at the time. Severe pancreatitis causes a phenomenon we call third spacing.
Third spacing, what does that look like in the body?
Imagine your body has three main fluid spaces. The first space is inside your cells. The second space is your blood vessels. The third space is the empty spaces between tissues and cavities, like the peritoneal cavity in the abdomen, which should normally be almost dry.
Okay, so the cells, the pipes, and the empty space.
When the systemic inflammation of pancreatitis hits, the blood vessels become incredibly porous. They act like a leaky soaker hose. The water component of your blood leaks out of the vessels and pools in that third space in the abdomen, creating massive swelling.
And if the water leaves the blood gets thick.
Exactly. The blood becomes thick like sludge, a condition called hemoconcentration. The heart has to pump furiously to push this sludge around. The kidneys, which require high-pressure liquid flow to filter toxins, dry up and start to die.
So you give them fluid to water down the sludge?
So, to prevent kidney failure and keep the microcirculation open in the dying pancreas, doctors gave massive, aggressive boluses of intravenous fluids. But in medicine, intuitive sense must always be tested against empirical data. And this raises a deeply important question. Was all that fluid actually helping the patient recover, or was it just treating the numbers on the monitor?
Enter the waterfall trial in 2022. I love when medical trials have great descriptive acronyms. The waterfall trial looked exactly at this early aggressive fluid resuscitation versus moderate targeted fluid. And the results were an absolute bombshell in the gastroenterology world.
They absolutely were. The trial defined aggressive fluid as giving the patient a massive 20 milliliter per kilogram bolus right off the bat in the ER, followed by a continuous rapid drip of 3 milliliters per kilogram every single hour.
That's a ton of fluid.
For a typical adult, that's nearly 1.5 liters of fluid instantly, followed by liters more over the next day. What the trial proved, unequivocally, was that this old standard provided absolutely no clinical benefit to the pancreas itself. It didn't stop the necrosis. But worse, it vastly increased the risk of fluid overload. We were essentially drowning the patients from the inside.
Because the blood vessels were still leaky, so you pump more fluid in, and it just leaks right back out into the third space.
Precisely. And it doesn't just leak into the abdomen. It leaks into the lungs. The excess fluid flooded the microscopic air sacs, the alveoli, causing severe pulmonary edema and respiratory failure.
You're kidding.
Patients who might have recovered on their own were being forced onto mechanical ventilators in the ICU because of our aggressive fluid therapy. The trial was actually halted early by the Safety Monitoring Board because the aggressive fluid arm was so clearly harming patients.
That is wild. The cure was causing the critical complication. So what is the new standard today? How do doctors hydrate them safely?
The new standard is moderate, highly individualized fluid resuscitation, and specifically using a fluid called lactated Ringer's solution instead of standard normal saline.
Why does the type of salt water matter?
Normal saline has a high concentration of chloride, pumping liters of it into a patient can cause hyperchloremic metabolic acidosis. It makes the blood too acidic, which actually worsens the systemic inflammation. Lactated ringers is more pH balanced and closely mimics human blood plasma.
And what about the volume?
The real shift is in the volume. Instead of just opening the IV wide and walking away, doctors now have incredibly precise physiological goals. The goal isn't just give more fluid. The goal is to give just enough fluid to maintain a urine output strictly above 0.5 milliliters per kilogram per hour.
Why that number?
That specific output proves the kidneys are getting exactly enough blood flow to function and no more. Simultaneously, they carefully monitor and aim to normalize the patient's heart rate, their blood urea nitrogen levels, their hematocrit, which shows how concentrated the sludge is, and their lactate levels. It is a nuanced, tightly controlled balancing act, constantly reassessed hour by hour, patient by patient.
Okay, so that's the fluid revolution. Stop drowning them, start balancing them. But the second part of this paradigm shift totally short-circuited my brain when I read it. The gut rest myth versus early feeding. Listen, if the organ that digests food is massively inflamed and destroying itself, and we know that eating food normally triggers the pancreas to release those dangerous enzymes, shouldn't we absolutely stop feeding the patient? Shouldn't we starve them, give them IV fluids only so the factory isn't stimulated and it can just shut down and rest?
That logic is exactly what governed medical practice for decades. It was called NPO nil per os, nothing by mouth. Patients were kept NPO for days, sometimes weeks. It was considered the absolute unshakable cornerstone of pancreatitis therapy. Rest the gut, rest the pancreas.
Makes total sense logically.
But again, this raises an important question about unintended biological consequences. We were so focused on resting the pancreas that we ignored what happens to the intestines when you stop using them. When you starve the human gut for a prolonged period, the mucosal barrier, the inner lining of the intestines made up of tiny finger-like projections called villi, begins to atrophy. It shrinks and breaks down.
The wall gets weak.
Exactly. The tight junctions between the intestinal cells start to pull apart, and your intestines are a hostile environment. They are full of trillions of bacteria. When that mucosal wall gets weak from starvation, those bacteria translocate.
They escape.
They literally slip through the cracks in the weakened barrier, enter the bloodstream, and travel straight to the necrotic, dying, nutrient-rich tissue of the pancreas.
Oh my God.
We realized that by starving the patient to rest the pancreas, we were essentially opening the gates for overwhelming bacterial sepsis. The infected necrosis was often being caused by our refusal to feed the gut.
So the treatment was causing the deadliest complication. This is a recurring theme. So what do doctors do now? Do they just hand them a burger?
The modern approach is early enteral nutrition. Enteral meaning using the normal gut pathway. Clinical guidelines now strictly dictate that feeding should begin within 24 to 48 hours of admission, even in moderately severe cases. If the patient's pain is controlled and they aren't actively vomiting, you let them eat by mouth.
But surely it has to be clear liquids, right? Broth and water.
Surprisingly, no. Modern studies now show that starting directly with a low-fat, solid diet is actually preferred and better tolerated than starting with just clear liquids. The gut needs solid nutrients to rebuild that mucosal barrier quickly.
That is completely counterintuitive but amazing. Feed them to save them. But what if they are vomiting? What if the pain is too much and they physically cannot eat?
Then doctors will insert a feeding tube. They will run a nasogastric tube down the nose and into the stomach, or a nasojejunal tube that bypasses the stomach entirely and goes straight into the small intestine. They will pump a specialized, pre-digested liquid nutrition directly into the gut.
To keep the barrier strong.
The critical objective is simply to keep nutrients flowing over those intestinal villi, to keep that barrier thick, healthy, and intact, keeping the bacteria locked inside where they belong. We only resort to parenteral nutrition, which is feeding them chemical nutrients purely through an IV directly into the veins as an absolute last resort.
Only if the gut is totally broken.
We only do that if the gut simply cannot tolerate food or is completely blocked after 5 to 7 long days of trying, because IV nutrition does absolutely nothing to protect the gut lining.
It's just a complete 180-degree turn in medical logic. Okay, so we have the fluids balanced and food is in the gut. What about the pain? Because as we've established, having your pancreas melt inside you is agonizing. How is that managed?
The pain in acute pancreatitis is incredibly severe, often described as a constant, boring pain radiating straight through to the back that makes it hard to even breathe. Management follows the World Health Organization's strict 3-step or 4-step analgesic ladder. Because of the sheer severity, you can't just give them Tylenol. Most patients immediately bypass the lower steps and require step 3 agents, which are powerful intravenous opioids.
I saw hydromorphone and fentanyl listed as the preferred drugs, and they often use PCA pumps, patient-controlled analgesia.
Yes. A PCA pump is a brilliant tool. It's a machine connected to their 5E. The patient has a button they can press to give themselves a safe microdose of pain medicine precisely when a wave of agony hits.
So they don't have to wait for a nurse.
Exactly. It's programmed with strict lockout so they can't overdose, but it gives them psychological control and keeps the pain medication levels steady in their blood rather than enduring the peaks and valleys of a nurse giving an injection every 4 hours.
But there is a crucial, very specific detail regarding pain meds that I want to highlight. Doctors absolutely avoid a specific drug called meperidine. Why is that?
Meperidine, which is also known by its brand name Demerol, used to be heavily favored by older physicians. There was an old, largely debunked theoretical belief that it caused less spasms in the sphincter of Oddi, the muscle at the end of the bile duct, compared to morphine.
But there is a catch.
However, meperidine has a fatal flaw. When the liver breaks it down, it creates a toxic metabolite called normeperidine. This metabolite accumulates quickly in the blood, especially if the patient's kidneys are struggling due to the pancreatitis.
And what does normeperidine do?
And normeperidine is highly neurotoxic. It poisons the brain. It can cause severe tremors, agitation, hallucinations, and massive grand mal seizures. The risk of neurotoxicity far outweighs any theoretical benefit to the bile duct, so it is strictly avoided in modern practice.
Got it. Keep the brain safe. Okay, let's talk about antibiotics. With all this dead necrotic tissue potentially sitting inside the abdomen, do doctors just flood the patient with prophylactic antibiotics? Do they just carpet bomb the system with penicillin to prevent an infection before it starts?
They do not. And this is another major shift away from the old dogma. Prophylactic antibiotics, meaning giving them just in case before an infection is proven, are explicitly not recommended by modern guidelines, even if the patient has widespread, massive sterile necrosis on their CT scan.
Why not? If the tissue is dead, won't it inevitably get infected?
Not always. And giving broad-spectrum antibiotics when there isn't an active infection is incredibly dangerous. It decimates the healthy microbiome in the gut. It breeds antibiotic-resistant superbugs in the hospital, and it drastically increases the risk of terrible fungal infections, which are much harder to treat.
So when do they actually pull the trigger and use them?
They reserve antimicrobial therapy strictly for when an infection is definitively confirmed, or there is overwhelming clinical suspicion of an extrapancreatic infection. For instance, if the patient has a concurrent cholangitis, that infected bile duct from a stuck gallstone, or if they develop a hospital-acquired pneumonia or a urinary tract infection from a catheter.
What if the pancreas tissue itself is infected?
If the doctors specifically suspect that the dead pancreatic tissue itself has become infected, maybe the patient's fever spikes again on day 10, and their white blood cell count shoots up. They still won't just guess. They will often perform a CT-guided fine needle aspiration.
What is that?
A radiologist uses a live CT scan to carefully guide a long, thin needle through the patient's abdomen, dodging the stomach and intestines, directly into the pool of dead pancreatic tissue. They pull out a sample of the sludge and send it to the lab to culture it.
To see what's growing.
Right. If the culture proves there are bacteria actively growing in the necrosis, then and only then do they deploy targeted antibiotics. And often, antibiotics aren't enough to penetrate the dead tissue. They will have to arrange for surgical or endoscopic drainage, putting physical drains into the abdomen to suck the infected sludge out of the body.
It's all incredibly precise. No more guessing, no more shotgun approaches with fluids or antibiotics. Measure, verify, and target. And finally, fixing the root cause. Because you can survive the acute attack, you can survive the ICU, but if you don't remove the spark, the factory is just going to explode again next month.
Exactly. Acute care saves the life today. Definitive treatment prevents the death tomorrow.
For suspect number 1, gallstones, the fix is purely structural.
Yes. If a stone is actively stuck in the ampulla during the attack causing cholangitis, they perform an urgent ERCP to snare the stone and pull it out of the duct, relieving the pressure. But that's not enough. The gallbladder is still full of stones. Crucially, before the patient is even discharged from the hospital on that same admission, the surgeons will perform a laparoscopic cholecystectomy to completely remove the gallbladder.
They just take the whole thing out.
If you just send them home and tell them to follow up in a few months, the risk of another tiny stone slipping out and causing a recurrent, potentially fatal attack within weeks is unacceptably high.
And for suspect number 2, alcohol.
That requires structured, compassionate, and aggressive behavioral intervention, inpatient addiction counseling, social worker involvement, and immediate referrals to outpatient behavioral health. It's a disease of addiction driving a disease of physiology. It also requires a dietitian to address the severe malabsorption and vitamin deficits chronic drinkers often have, and endocrinology screening for new-onset diabetes.
And the rare causes get highly targeted fixes too. If it's those sky-high triglycerides over 1,000 turning the blood milky, doctors will use continuous insulin infusions, which helps drive triglycerides back into fat cells, or they use plasmapheresis, literally hooking the patient up to a centrifuge machine and filtering the fat right out of their blood plasma in real time.
It's amazing technology.
If it's autoimmune pancreatitis driven by those IgG4 targeting lasers, they use targeted corticosteroids like prednisone to suppress the immune system and shrink the swelling. Every unique spark requires a completely unique extinguisher.
It is truly a masterclass in multidisciplinary medicine. You have ER doctors, radiologists, gastroenterologists, surgeons, dietitians, and intensivists, all orchestrating this incredibly complex dance to save one organ and one life.
So, to summarize this massive, incredibly complex journey we've been on, we started by peering into this hidden, explosive chemical factory tucked deep behind our stomachs, marveling at the sheer destructive potential of our own inactive digestive zymogens. We navigated the terrifying maze of the ER triage, learning how this disease perfectly mimics ruptured aortas, dying intestines, and heart attacks, and why cognitive bias is a doctor's worst enemy.
It's a treacherous landscape.
We interrogated the primary suspects, the migrating microscopic gallstones causing plumbing disasters, and the toxic power-draining pathways of chronic alcohol. We plunged into the truly weird, fascinating wilderness of scorpion venom, giant parasitic worms crawling up ducts, and tiny genetic typos.
The full spectrum of triggers.
And finally, we explored a medical revolution, the humbling realization that drowning the pancreas in saline and starving the protective gut barrier were actually causing profound harm, ushering in a modern era of precise, moderate hydration and early protective feeding.
It is a remarkable story of how scientific understanding evolves. We move from intuition to evidence. But stepping back, it also leaves us with a rather profound realization about our own biology.
What's that?
We think of ourselves as so robust, but if an organ designed so perfectly to sustain us, to meticulously break down the nourishment we need to survive, can so abruptly turn its awesome power on itself, sparked by something as mundane as a 5-millimeter stone, a lipid imbalance, or an entirely invisible genetic mutation, what does that say about the incredibly fragile, biochemical tightrope we walk every single day?
It's humbling, to say the least. It makes you realize just how much goes perfectly right inside us every single second, just to allow us to exist. Thank you all for coming along on this deep dive. Take a moment today to appreciate the quiet, vastly complex machinery working continuously in the dark inside you. See you next time.